Good morning. ARDS is a subphenotype based on the size of the baby lung and compliance. This title reflects a very hot debate that we have in our community during the COVID pandemic, and that we still have. Now, these are my conflicts of interest. Okay, let's go. ARDS, what we know about ARDS. What we know about ARDS, let's call classical ARDS, since Asbach and Pett in 1967, derive from a database of studying patients mostly with pneumonia, bacterial pneumonia, or abdominal disease, leading to generalized sepsis. These patients represent about 80% of the starting population from which all the big studies we did over the decades has been performed. And we have fewer patients with inhalation or other smaller category of disease. Now, already Asbach and Pett, what they found that at the end of the story, many different diseases lead to an inflammatory edema formation, which reduce the lung ventilable size because the water steals space to the gas, and the ventilable lung is reduced to the size of the lung of the baby, 300, 400, 500 milliliters instead of 2 liters and a half. And of course, if I have a very small baby lung mechanics are down, compliance is low, the gas exchange is impaired because of the right to left shunt, that means the blood flowing in the not open lung, and the hemodynamics are problematic because the poor heart, the right heart, has to pump against this complex anatomical situation. Now, the reason for what the RDS was invented was that they found, okay, maybe the similar final picture require a similar, a common respiratory treatment. And this was not really wrong because the people wrote at the volume, etc., etc. And we start with Asbach. They had, okay, if you have a patient with a heavy lung, well, of course, this is at the autopsy, or you have bilateral infiltrates, have a low compliance and severe hypoxemia, refractory hypoxemia, that means refractory to what? To the oxygen. This is called adult respiratory distress syndrome versus the infant respiratory distress syndrome. And that has been changed in acute respiratory distress syndrome. And with time, we reduced the definition. So the mechanics disappear, the heavy lung disappears, and what we remain? We remain with bilateral infiltrates without further specification, 5 of people at least, to have not refractory hypoxemia, but even with 300 or 200, which is not refractory hypoxemia according to Asbach. Asbach was refractory below 100, and this was done why? For one simple reason, to allow the conduction of a randomized control trial, because if not, the enrollment was too low. This is the only reason for grouping. It was a good reason, and overall, ARDS was our syndrome because intensive care can proceed with the ARDS evolution. Now, it's not an academic question if ARDS with COVID is typical or atypical. If it's typical, what is the problem? You take the NIH recommendation, you take the sepsis campaign recommendation, and you say, okay, treat the ARDS of COVID as a normal ARDS. So take care of hypoxemia with the table, etc., etc. But if ARDS is atypical, the treatment should be the typical treatment, or you have to think to something different. And remember that this disease had a mortality in intensive care going from 10 to 90%. That means the treatment play a role because the disease is the same all around the world. And now let's see. I take a series of COVID patients arriving in the hospital with a hypoxemia, mostly with hypoxemia, and with bilateral pneumonia, bilateral infiltrates. And in the group was not ARDS because they were not below this magic number, 300. But other patients had mild, moderate, severe, and severe ARDS below criteria. These are COVID. No question, they are under the umbrella of ARDS definition. Good. Now look at the lung weight or the lung condition, the anatomical condition, are exactly the same, completely independent on the hypoxemia. Means that the mechanism of hypoxemia are not the same as the classical ARDS. Well, they are correlated with the lung weight. Look at the gas. This is the sternum, this is the vertebra. At each level of the lung, we have double gas compared bacterial pneumonia. And these were 32 patients, pulmonary ARDS matched. To me, it's difficult to understand how it's possible to ignore these facts. But for emotions or for some prejudice. And this was the first observation we did during the first wave. After the very first few patients, we found that about there were 16 patients, if I correctly remind, and about half of them had a compliance greater than 50. And you saw, what is the problem? In ARDS, classical ARDS, we might have a compliance greater than 50. Great, but tell me how many of classical ARDS have a compliance greater than 50 and right to left shunt greater than 30. That means a severe ARDS criteria. In 40 years, I didn't find much. Really, I didn't find any before COVID pandemic. And of course, when you have higher lung volume, you have a respiratory system compliance, which is high. And this patient in this condition, this is COVID after days, and you see, would deserve the same treatment? They have ARDS, both have infiltrates, 95 PO2-FiO2, 84 PO2-FiO2. Both of these conditions meet the severe ARDS criteria. Means that the hypoxemia mechanisms are different. Look here, this in normal ARDS, these regions, which are more dense, are hypoperfused because you have hypoxic vasoconstriction, which still exists. And in this region, you're very happy because, well, these are good lungs. Now, when you go to perfusion, look at this COVID patient. Look, what is the perfusion of this patient? Where the perfusion is supposed to be low, is very high. And when it's supposed to be good, no perfusion at all. This is called VAQ mismatch, which is the basic problem of this patient, which is not cured increasing the pressures and increasing PEEP. So COVID-19, lung weight, lower, higher, gas volume, adult lung, baby lung, compliance, higher, lower, imaging, ground glass, patch, hypoxemia, VAQ area. Are they so similar? And when we say, okay, let's call the different status in different way. Let's call type L, that means good compliance, VAQ mismatch, no recruitability, lung weight. And let's call type H, the very severe ARDS. Also, a lot of colleagues become furious about that. But this is the common observation on this patient if you have the time on the right axis. You cannot put together all these patients and publish a low-level epidemiology paper. You have to discriminate. We had to discriminate to understand the nature of the disease. And so, in general, what COVID taught me personally, I think you say, okay, we start to look at personalized treatment in ARDS, no? And we have, maybe not ARDS are similar, no? We have at the beginning pulmonary versus extrapulmonary. Somebody say are different, somebody say are indifferent. You have meta-analysis, you may have whatever you want, but still you have the thinking that pulmonary may be different from extrapulmonary. Great discovery, pneumonia is different from peritonitis. Good. Then we have the latent class analysis, which are not very latent. Sometimes are very manifest. And you have COVID versus not COVID. And pulmonary versus extrapulmonary. Of course, you may have a different compliance, a different chest wall compliance, different mechanisms behind. And latent class analysis, you always have this beautiful line, one going up and one going down. You have, oh, these are more inflammatory than the other, which are less inflammatory. And in whatever population you can do something similar. And you most of the time you find a difference. Because the patients are different. With the personalization progress, LDS still makes sense. Because if you think the personalization is exactly, but exactly the contrary of the syndrome. The syndrome put everything together in the same bouillabaisse. And the personalization try to extract, oh, okay, this is this kind of fish, this is another kind of fish. Tends to separate and to take care of every single patient. I think this has been, at least for me, the great lesson of COVID. But I think we are very far from having consensus on this topic. But remember, the mortality in intensive care of this patient goes from 10 to 90%. And not because all the more severe in one intensive care and all the less severe are in the other intensive care. There is something different behind. Basically, this is a disease which evolves with time. To understand this disease, we have to take the time in consideration. I thank you for the attention.